Morning, everyone. The Finance Committee will please come to order. Thank you all for being here. Any citizens signed up to address the committee? We do not. All right, we'll move on to item 3, which is approval of the minutes from the August 23rd meeting. Any questions? And I'll entertain a motion. Motion by Dr. Weber, second by Mr. Bose. All in favor, please say aye. Opposed? Motion passes. CFO report, Ms. Clark. Good morning.
For today, I just wanted to remind everybody that Sunday is a very big day. It is the 30th of September, which will close out fiscal year 18. So there are a lot of activities that are happening. The medical center gets to inventory a lot of different areas. There'll be staff up here on the weekend doing that. And thank goodness it only happens once a year.
Yes.
Our fund from a finance side will really start in about a week when we start to close the final year end. There are quite a few unknowns still that we are working through. The most significant, which is our federal funding programs. As you might recall, our district program is no longer on a 9/30 year end. It's on a 12/31 year end, a calendar year, because of the late implementation. So we are having to estimate our performance on that. And then there are still a lot of open items and unanswered questions as we work through some final federal funding questions for both UC and DISH. So more to come, yes.
Pictures at 11.
So unless you have any questions for me, I'm just going to go ahead and move on into the financial presentation.
That'd be great. Thank you.
Okay. Where's the clicker? I think I don't have my...
I saw one on the podium up there. Oh, there's one.
It's on the podium, I believe.
Is that it? That's the microphone.
Do we have a clicker, maybe?
Hello to the control room. Do we have a clicker?
So...
There he is
There's-
to save the day.
There's the man with the plan. Thank you,
Way to
Derek.
go, Derek.
Thank you, sir.
I think they were probably a little bit more panicked than I was, so that's
Yeah, but
okay.
don't ever doubt the power of Derek. Because if he had not walked in here, we couldn't have done anything. So that shows-
Y'all would have been
Picture, if you will.
pretty, there's a lot of numbers without any pictures. All right, so admissions this month for August were really high. If you look at that blue bar as it trends across, it was the highest it's been all year, and we were about 9% over budget. Trending as well as our patient days, and our case mix index, interestingly enough, is slightly under as well. You can see here with the blue bar being a little bit under where we were last month. Our length of stay continues to be over budget, but you can see that relative to the red line, this month did come in at, let's see, the actual number is 4.61 compared to a 4.47. That's the lowest it's been in quite a few months. So there are a lot of efforts from an operational side surrounding appropriate discharges and making those timely. For our emergency department, you can also see we were right on budget, about 1% over. If you look at the year-to-date number, we see on average 316 patients a day through our emergency department. And then when you look down at urgent care, that number is an additional 146 per month. So there are almost, 500 people coming on a daily basis to seek care, and we're able to accommodate that.
Yes, sir.
Your graph says it excludes ER triage. Where do those people go? Who are they?
So we don't show you 100% of our statistics. ER triage, if you left without being seen in the emergency department, then it's not captured in this specific number for visits. If they don't see a physician, we're not able to drop a charge for those patients.
So we don't do anything at all if whoever's doing the triage says this one can stay.
And the reason that we denote that, the way that we're presenting it to you in the Finance Committee report is industry standard, and we're actually counting E&M codes, levels 1 through 5, that come through the emergency department. However, that note just tells you there is a lot of work for patients who are triaged only and are not dropping an E&M code.
So we don't,
So-
no reimbursement for the triaging.
Correct, there is none. So it's just it's really telling me that we're counting it in this way. It's really just the E&M codes. The work is still being performed, but typically you don't count that when you're trying to compare across hospitals.
So if there's no E&M code, then any physician and/or nurse practitioner work doesn't show up there.
Correct.
Okay.
But it does still take some staff time.
Sure.
And, I think years ago, we may have included some of those visits when we were more on a manual count. And over the last several years, and all these years have been restated to be consistent. But
Well, I guess my last question would be, how do the people doing all the work get recognition or compensation? I mean,
Well, so this is just statistics of patients, again, that have been seen by a physician in the emergency department.
okay.
As far as compensation goes, our staff aren't compensated based on any
I was
kind of a
thinking
volume
like
number.
these guys.
Those contracts, there may be some incentives that relate to the quantity, but typically that's more of a coverage arrangement in the emergency department.
Okay. Thank you.
You bet. Our primary and specialty clinic visits continue to be right on trend. We're about 1% under in primary care for the month, but you can see just how many that we've had. It's probably our second highest this year. And the specialty care visits are about 2% over. So we are picking up volume for them as well. Observation cases, you can see they are down with the inpatient volumes that we have. You're either inpatient or you're observation. So if inpatient is way up, it makes sense for the observation cases to be down in a similar complement. Invasive lab continues to have a very strong year. If you look at the gray bar, which is 2 years ago, the tan bar is last year, and the blue bar is this year. The red line, again, is budget. We had a very strong month this month. You can see that it was about 9% above budget. And I do want to point out our surgery volumes. We have actually about 3% ahead of budget for inpatient surgeries. A lot of those patients came in through the ED this month, but we've kind of had a slow ramp up recently. Probably if you put a trend line in there, it would be going slightly up. And so it's good to see our inpatient surgeries back on track. Outpatient, although they were significantly ahead of last month, we just missed budget by about 9%. Our psychiatric area, you can see the patient days were favorable, about 5% ahead of budget. Our clinic visits, again, we started with a very aggressive clinic budget. I think if we could go back and restate that, we would have put them back at the normal level. But if you compare the blue bar to the prior year, you can still see that we are having a much higher volume this year in the psychiatric clinics than we did last year. The psych emergency clinic is down by about 13% from budget. It looks like from a budget standpoint, we're trying to keep it about even with the prior year, and we've been able to increase our clinic visits and decrease the emergency department. And our financial metrics, the days cash on hand is about 181 days. You can see that it's sloping down in the normal trend. However, this month we did have 3 pay periods that hit twice a year. We have 3 big drawdowns for our payroll. And our net AR is down to 48 days that it takes us from the time we drop the bill to the time we collect it. FTEs continue to be favorable at 5.59 compared to our budget goal of 5.8 per patient day. Connection held pretty steady this month. We didn't see a large growth, but we're able to maintain our enrollee number just under 40,000
Are you going to call this the
enrollees.
Montgomery graph?
Pardon me?
Are you going to start calling this the Montgomery graph?
Yeah, I can rename it, or maybe we could just superimpose a picture of you for next month. I'll work on that.
Yeah, no, be careful, right? I know.
We also, for the month of August, the medical center did miss their budget, and most of that was down in the purchase service area with some quality incentive payments, which is a good thing. As we approach the end of the year, we're able to start to really measure where we are at and some of the liabilities that come from some of the incentives in our physician contracts. And we did have some acclaim funding that went over as well. The other large variances are kind of a wash for the most part. Again, we did have a lot of additional revenue in net patient service. 2 reasons. Number 1 is the volume, and number 2 is the URIP program. If you recall, and I explain this to you guys every month, and I apologize for that, but it's a very complex program, and
Yeah, don't apologize.
we budgeted for that in a very different way than it's actually occurring. So there's large budget variances that come through. But the way that we used to IGT for our community partners is we would offload physician contracts, and our partners at TCICC would take on those expenses, which would give us room in our budget to expense the IGT that was sent up for both DISH and UC. Under the URIP mechanism, now what happens is that we pay those physician contracts directly down in purchase service, and we have that IGT expense. So it kind of doubled up on our expenses. But the way that we get our budget revenue back is up here through our Medicaid managed care payments. And if you recall, when the board approved our participation in the LPPF and the URIP mechanism, we were also approving our contracts with Cook Children's, with Aetna, Amerigroup, and now Cigna to pay us more. So HHSC works with those managed care companies to pay them more PMPM, and they in turn give it to us as we see those patients. It's a
We
very
take from
complex
here and add up
transaction.
there.
So these two relatively offset each other. We did have some underages. First of all, is there any questions that y'all have about the budget variance because of those? The good news is that we've got one more month of this mismatch, and then when we begin 19, we did budget for the URIP program correctly, so there won't be these large variances that come out of these transactions. The other large variance that I want to point out is the underage here. A lot of that is due to our pharmaceutical assistance program budget, where we have an offset and down here in supplies. I drew that wrong. In supplies for decreased medical supplies. So that's actually a zero impact on our income statement. So for the month, we had a loss of $712,000. If you look at year-to-date, we're at about a $400,000 loss compared to a $3.6 million budget, and our bottom line is $11 million. Any questions for August? Okay. For a claim, we have, you might see that we kind of spiked the budget in August for encounters. That's because we are actively recruiting several positions. And we missed budget by about 12% this month. The good news is that down in the net operating expense per encounter, right there, year-to-date, we are about 7% under our expense per encounter for a claim. And, you know, that just kind of right-sizes all of the underages that we have in volumes. How are we doing per click? And it is favorable. For a claim, they had a favorable income from operations or loss from operations. They budgeted $560,000. They did about $200,000 better than that. Again, we've talked about these variances with a claim. It's very consistent month to month. The underage and net revenue mainly is due again to the underages and encounters. And then we have some budget savings, especially down here for both CME and recruitment expenses.
You know, I've watched the claim over the last few months, and it's kind of been consistently losing less than what we anticipated. I mean,
Yes.
I think last month and the month before. So it's
Correct.
great.
So if you look year to date, they're running about $1.7 million ahead of what we anticipated for a claim.
One of the challenges, Steve, is our next operating committee, the claim executive committee, I want to lay out the challenge of increased income sources so that we can dent that a little bit.
Right, yeah.
Because I think there are opportunities that have not been tapped, but that's just me thinking, so we'll have a report for you in November.
Great.
So when you look at us combined year to date, I'm going to have trouble circling this, I think. There's something that's blocking me here. That's okay. We'll work on it. 9.6 million loss from operations compared to a budget of 7.8. So we're just under about 2 million. But when you look at the bottom line, can't draw in that corner. When you look at the bottom line, it's right on budget. We're at 1.808 actual with a budgeted income of 1.863. So razor thin. Any questions on the financials? Okay. A new year, well, not yet. We've got one more month to go and it's a doozy. Sure. I'm going to be requesting approval on Apex Technologies. They are the incumbent. We did go to RFP for this renewal. They are the ones who actually, after about the first 60 days, they send out our paper billings to all of our patients. And the 19 budgeted cost is about $360,000 a year. It is a 3-year contract for $1,080,000. C is a bit unusual. We are asking for, it's considered a real estate lease, 16 square feet for an ATM that resides in our pavilion. 16 and a half feet, 0.4. Thank you, Mr. Chair. So yes, it is a real estate lease. This is why you guys are looking at it. Chase provides us this ATM at no cost to us, which is a true benefit for our employees and our patients. It is. They provide two. All right. Thank you.
Good morning.
Hey,
I'm
I'm
sorry.
going to compliment you on your haircut.
Thank you very much for the board meeting.
You do it yourself?
I won't answer that question, depending if you like. Speaking of real estate transactions, we're seeking approval of a purchase agreement for a building at 200 West Magnolia. That is a 2-story, 12,825 square feet building strategically located right across the street from JPS. So it's within walking distance of the main campus. As we've discussed, we already lease about 1/4 of that building. A net present value of purchase versus lease would show that this is of net financial benefit to the district as well.
And this came through planning committee?
That's correct.
Great.
And Mr. Petty is aware that it's on the agenda today.
All right. So any questions for Scott on this item? I know we've talked about it for a few months now, so. Motion by Mr. Bose, second by Mr. Powell. All in favor of the motion, please say aye. Opposed? Motion passes. Thank you, Scott.
Thank you.
Dr. Elliott. Good morning.
Good morning. Good morning on this beautiful fall day.
Oh, isn't it awesome out there? We should hold these outside instead.
Yeah. Thank you, Mr. Chairman. So I am here to seek approval from our board here for the approval of the Second Amendment to the Medical Education Affiliation Agreement. That's between the University of Texas Southwestern Ophthalmology and Tarrant County Hospital District that really helps us support our ophthalmology program in partnership with UT Southwestern. You'll see there in your document that we have a $504,076 annually proposed. That's an increase from our previous First Amendment, but it does align well with the formula that we've created that we will be using throughout, and does align with what we're trying to provide for our residency
And
education.
it is in our FY19 budget.
Is within our budget, absolutely. Thank you.
Any questions for Dr. Elliott? Entertain a motion. Motion by Mr. Bose, second by Dr. Weber. All in favor, please say aye. Opposed? Motion passes. Thank you, Trish.
Thank you.
Trudy Sanders. Yes. Good morning, Trudy.
Good morning, and I'm here for Wanda today. The first agreement is a purchase agreement between K2M and Tarrant County Hospital District, and this agreement is a result of an RFP, and it's for equipment, instruments, and implants for the orthopedic surgeons and neurosurgical surgeons for elective and trauma procedures. And with this new agreement, we will have substantial annual savings and an increase in potential savings over 5 years if the 2 one-year renewal options are exercised.
Okay, any questions for Trudy?
I don't have a question, I have a statement I'd like to make about this.
Yes, ma'am.
I have no problem with us approving it, but I look at the information that they provide to us, too, I know we didn't do this, and nothing applies when we ask on diversity. On the others, nothing applies, but they still give us their FTEs, who they have in their department. This one
Right.
is like, okay, we don't do anything, so they didn't even share their employees. So could we get a little consistency that if they don't do anything and saying, we ain't gonna do this, at least they would.
Comply with the rest of it. Right.
But I move approval.
Thank you.
So noted, please. We have a motion. Do I hear a second? Second by Dr. Weber. All in favor, please say aye. Opposed? Motion passes. Thank you, Trudy.
Okay.
Are you going to do the next one, too?
Yep.
Okay,
Yep,
thanks.
still here. The next agreement is with UHS Surgical Services, and this is a Vizient contract to provide laser services, labor fibers, and lithotripsy services for the surgical specialties. And again, we will have substantial annual savings and additional saving opportunities by utilizing this agreement.
And this is within the FY19 budget, correct?
Correct.
Okay, any questions for Trudy? Motion by Mr. Bose, second by Mr. Nguyen. All in favor, please say aye. Opposed? Motion passes. Thank you, Trudy. Ms. Costin. Good morning.
We're here this morning to discuss the renewal of our 3M support contract. I think all of you are aware that before we can bill for any of our services, we have to medically code what happened, what did we actually do in order to get paid. And what the 3M software does for us is make sure that our documentation is as robust as it can be, so that we are actually getting reimbursed for all of the services that we are providing. This is an annual support fee from 3M, where they do actually have the capability of giving us suggested coding based on what they see in the documentation. That is their computer-assisted coding module that we've been using for quite some time, has been very effective for us.
Is it integrated with our EHR?
Excuse me?
Is it integrated with our EHR?
It is indeed.
It is, awesome. Okay, any questions for
Are
me?
we using IMO also as well?
IMO?
No?
No, we're not. We're just using this.
Just this one, not the other one?
Yes.
Does it have the capability later on for perspective coding?
Yes, we're looking at perspective coding. I'm so glad you mentioned that, absolutely.
Melinda, would you do me a favor for Dr. Weber? Will you explain DT's question on that, what was included in that?
Didn't rehearse that early? No.
I understand. It's not going to be what, it's a term that Dr. Weber's probably unfamiliar with, so if you would.
IMO coding?
No,
Yes.
no, the prospective county.
Oh, perspective.
Being able to look in advance to see what we think, what we think is going to be happening with that encounter.
Data analytics that will tell
Hopefully,
us
it will be
predictive
helpful
analytics.
later on as we move toward more value-based type thing. Potentially looking at risk scoring and all that stuff for coding.
This one also has language of best practice,
Evidence-based.
go on record as I'm against that type of language. I think it should be evidence-based.
Right.
That's a good point. This,
And we're trying to get out of that vernacular, and we haven't gotten quite out of it. We agree with you.
I don't think the vendor, we can subject the vendor to that, because the vendor is going to use best practice, is how we do internally. I don't think they can take that responsibility.
Coding and billing, there may be a
Best practice. Mhm.
Okay, you've heard the description from Linda. We've got a motion by Dr. Weber, second by Mr. Nguyen. All in favor, please say aye. Opposed? Motion passes. Thank you,
thank you
Melinda.
very much.
Zelia, talk about MHMR.
Good morning.
Good morning.
I've been asked before I go through each individual contract to kind of give a brief overview of our relationship with MHMR, because all three of these contracts are with MHMR. We have an outstanding relationship with MHMR in the community, and they are the local community mental health center, and so they are also the financial conduit, so to speak, from the State Department of Mental Health that goes into local community dollars. And so our relationship with them.
Attention, please. Code red. Tower, lower level cafeteria. Attention, please. Code red. Lower level tower cafeteria. Attention, please. Code red. Lower level cafeteria.
Haven't you always wanted to say something like that?
We seem to have a high propensity to say it when y'all are here.
And so our relationship with MHMR has been amazing, and it was actually one of the reasons why I wanted to come here, because it's not common across the country to have such an excellent community partner that we do with MHMR. And so, again, like I was saying, they act as a conduit from the state dollars to be placed into the local community to help with dealing with people with serious and persistent mental illness at the local level. And so these three contracts actually allow us to be able to do that in partnership with MHMR. And they're actually revenue contracts. MHMR pays us money to help provide services on the inpatient level. And so I wanted to ask if anybody had any questions before I proceeded.
Thank you for that. I'd actually asked for that kind of overview. I know we've had a long-term relationship there, and I didn't know if everyone really understood the context of it, so I appreciate that.
Sure, no problem. Thank you.
I do have a question.
Yes, sir.
When we manage the inpatient, right,
I was the only one.
when it comes time for them to go on the outpatient side, do they go back to MHMR?
It depends on what's going on with the patient, because if MHMR is the appropriate outside resource, then yes, they would. However, if we're the appropriate outside resource, then they would stay with us. Yes, sir. It can go either way.
Okay. Let's go to item I.
Okay. Asking for your approval for a professional medical services agreement between MHMR, Tarrant County, and our Tarrant County Hospital District. This is a revenue contract in the amount of $5,723,200. This is funding for our long-term commitment unit. So that unit is in lieu of patients going to a state hospital, which allows us to keep Tarrant County residents here in Tarrant County and being treated locally so their family members and support system can participate. So this is a renewal of that contract, but for the 28 beds in what we currently now call Trinity Springs North.
Okay. Any questions for Zelia on this item? I'll entertain a motion. Motion by Dr. Weber, second by Ms. DeBose. All in favor, please say aye. Opposed? Motion passes. Thank you. I agree.
I also will add to what Zelia said in that Susan Garnett at MHMR is an incredible partner for us. And she understands what we do and how we do it and is constantly trying to figure out ways to be efficient with dollars and try to help us in some of the nuances of the state side that we don't see every day. So Susan is a huge benefit to our patients and to JPS.
Absolutely. She's helped me a great deal since I've been here already. The second contract is a professional.
Attention, please. Code red, all clear.
Yay.
Tower, lower level, cafeteria. Attention, please. Code red, all clear. Tower, lower level, cafeteria. Attention, please. Code red, all clear. Tower, lower level, cafeteria.
Right. I'll take that as good news.
It is good news, yes. Approval for professional medical services agreement between MHMR Tarrant County and Tarrant County Hospital District. Again, this is a revenue contract in the amount of $2,467,000. And that contract is for the Tarrant County Hospital District to provide treatment to indigent patients with severe and persistent mental illness that are affiliated with MHMR in need of inpatient hospitalization. So it's to help offset our costs for those indigent patients.
You've heard the description. Any questions for Zelia? I'll entertain a motion. Motion to approve by Ms. DeBose. A second by Dr. Weber. All in favor, please say aye. Opposed? Motion passes. Thank you.
Thank
Item
you.
K, please.
The final contract for us is the interlocal agreement with MHMR of Tarrant County for assisted outpatient treatment services. This is a revenue contract in the amount of $7,083 per month, not to exceed $85,000 for the year. This contract pays for an MSW social worker who works with MHMR and also the probate court offices to identify patients that are appropriate for what's called an outpatient commitment. So instead of them going to the LCA or a state hospital, they would have stronger wraparound services to be at the community level on an outpatient commitment. So this reimburses the salary for the individual assigned to that, and that is through a federal SAMHSA grant that is passed to us.
Okay, heard a description. Any questions for Zelia?
Move for approval.
Motion to approve by Mr. Powell, second by Ms. DeBose. All in favor, please say aye. Opposed? Motion passes. Thank you very much.
Thank you
Appreciate
all
being
very
here.
much.
Mr. Chairman, only point I would make is we just approved 2 contracts that total over $7.9 million that we're billing MHNR, but I heard the word that helps offset expenses because we also approved an $85,000. And we've already talked about the great relationship we have with Susan and MHMR, but just so there's no misunderstanding, those are offset expenses. That's not like we're making $8 million off.
Correct.
It's an offset to our expenses, so
Correct.
thank you.
Had it been the other way around, Sharon would have made that
Yes, I
presentation.
kind of thought so. I just make sure we understand that
Well,
Yeah.
those expenses, thanks to SHR, they're paying a portion of those.
Right.
you are correct, and coming through the ER, we would have to treat them regardless.
Yes, it's a great relationship.
Yes, sir.
Absolutely. No, it's very important. All right, thank you very much. So item 6, any report from council?
Yeah, monthly I report on the number. In this case, we've changed this since you modified the contract limits with the authority for Robert. There were 30 contracts under $500,000. Those have been posted. That list has to your website. If anybody has any questions, you can
Any direct, immediate questions for council? All right, so with that, we have nothing enclosed, and at 10:43, we probably would have adjourned earlier, but somebody was late getting here, so we're going to adjourn at 10:43 a.m.